I would like to, first of all, say hello to everybody from Dubai, United Arab Emirates. And I would like to thank the three superb speakers for their presentation that actually highlighted the recent cardiovascular guidelines and treatment algorithm. Professor Chopra and myself will be glad to conduct the discussion session, and perhaps with the permission of my co-chair, I would like to have the first question to Professor Mitra and about the new elements of the guidelines. First of all, it's a very extensive and new guidelines, a lot of positive results, a lot of different algorithm for the treatment of heart failure came at the time that we already have problem in treatment of heart failure in the initiation of the previous three pillars of heart failure, and inability of the physician or unwilling of the physician to up-titrate the dose of the previous pillars. So don't you think it's a little bit overwhelmed for the whole heart failure community and colleagues around the world to treat heart failure?
Sorry, to me? So if I understand well, the question is whether titrating the drugs or just trying to have all the 4 drugs. There are some analyses which are very interesting, including one from the Swedish Heart Registry, which has been just accepted at the European Journal of Heart Failure. And they show that in general, the outcome is better for the patients receiving all the 4 drugs rather than less than the 4 drugs. So, I mean, my recommendation is to try to start all the 4 drugs and then concentrate on the titration. But and of course, the easiest thing is to start when they are in the market. Also for non-diabetic patients, the easiest thing is to start glyphosins, because these drugs do not need titration, single dose and single daily administration.
Thank you.
May I ask a question? First of all, I would like to request the audience to post their questions in the chat box so that we can answer them. So I have 3 questions. 2 of them are related together, and maybe Dr. Mehta or Dr. Rosano, any of them can answer. After the previous guidelines, I kept on asking at every meeting, why is aldosterone antagonist pushed down the guidelines? Because it always said that if person continues to be symptomatic, start aldosterone antagonist. Now, I would like to ask the same question about ARNI. We recognize that ARNI is more effective than the ACE inhibitors. You also mentioned in your guidelines that if a person continues to be symptomatic, switch over to ARNI. My question is that if it is more effective, why not give it a priority over ACE inhibitor or ARC? That's one. Second is, in ACE naive patients, starting ARNI is a class 2B indication. Considering that the maximum mortality occurs in the first month or so, and considering the fact that now we have a lot more experience with ARNI, isn't it more logical to give it a better recommendation so that more lives can be saved?
I start.
Yes,
as I wrote the guidelines and I have to defend them. Well, the problem is that when you write the guidelines, you also always have two extremes. One is the evidence, and the other is you have to not extremes. There are two guidelines. One is the evidence, and the other one is to give indications for clinical practice. So if you base yourself on the evidence, we may say that there is a strong evidence that ARNI are more effective than ACE inhibitors when used as a replacement to ACE inhibitors. But on the other hand, even considering the trials published after the guidelines were finished, and namely I'm thinking about Paradise and LIFE above all, LIFE-HF, which compared sacubitril/valsartan with an ACE inhibitor with the valsartan in patients with advanced heart failure, and also Paradise comparing sacubitril/valsartan with ramipril in patients with post-MI LV dysfunction or heart failure. Both these trials failed to show a striking, a significant benefit of the ARNI compared with the ACE inhibitor or the DRP. Therefore, I think also independently from what written in the guidelines, we do not have extremely strong evidence in favor of the ARNI as a first-line treatment. When we wrote the guidelines, we based ourselves on Pioneer-HF, but in this trial, outcome were assessed as a post-hoc analysis, as the trial was underpowered to have results on outcome. And this was done in patients hospitalized for heart failure. So I think we may be rather sure that if a patient is on long-term ACE inhibitor or ARB therapy, probably we may hypothesize that this patient develops a kind of resistance to the ACE inhibitor, and he may be more sensitive to the additional effects of sacubitril. Then what to use first, I think is left to the doctor, to the physician attending the patient. Of course, if the patient has high blood pressure or normal to high blood pressure, we have more reasons to start with an ARNI first. But it's clinical practice that is different from evidence. I don't know, Professor Rosano has to say more than me, but I know.
Yeah, no, I fully agree with what Professor Metra is saying. Basically, the evidence is just not there for starting ARNI as a first line. I mean, there's no evidence whatsoever. As Professor Metra said, the trials that followed Paradigm-HF failed to show any additional benefit over ACE inhibitors. And even in Paradigm-HF, 30% of patients that were recruited and they were excluded during the run-in because of side effects or intolerance. So it is important to maximize, not just to give the ACE inhibitors, but to maximize them and to replace the ACE inhibitors only if a patient is able to tolerate the maximum dose of 10 milligrams BED of enalapril or equivalent.
But, let me just persist a little bit. At the same time, you say that if a person continues to be symptomatic in chronic heart failure, switch over to ARNI. Isn't that implicitly recognizing that it is much more effective? And why should we not be using it in the beginning? I'm talking about chronic heart failure now.
No, not really. I mean, you know that the systems will get activated at different stage. And so you have initially an activation of renin-angiotensin-aldosterone system without other activation or without other inhibition of other systems. And therefore, it would, is a waste of money, resources, and also there will be no additional efficacy if you target those patients where the systems are not activated. So first of all, you need to be sure that you target the RASI and you target the increased sympathetic activation. And in those patients who are symptomatic, it means that they still have an activation of the neprilysin pathway. And in that case, the targeting also the neprilysin pathway, it can be effective. But using from the beginning, the ARNI won't give you any additional benefit compared to ACE inhibitors, and the evidence is not there.
Thank you. One more question, if I may. This pertains to IV iron. Estimating iron levels is a class 1 indication, and treatment of iron with ferric carboxymaltose is class 2. If the deficiency of iron is a class 1 indication, how come the treatment is class 2?
Sorry, can you repeat?
Yeah, okay, let me repeat. In guidelines, it says that we must estimate, we must do iron studies in patients of heart failure, given it a class 1 indication. But treatment for iron deficiency is a class 2 indication.
Yeah, but if I may, it's the same thing of using the biomarkers for diagnosis. You use a biomarker for diagnosis, then NT-proBNP, but you don't use it for follow-up and targeting therapies. So first of all, it is mandatory, so it's a class 1A because you need to identify patients who have iron deficiency. Then the class 2B, class 2, it doesn't mean that they shouldn't be used. It means that there is evidence but the evidence, it doesn't come from strong clinical trials. So whilst the evidence for iron deficiency causing mortality and reduction in exercise capacity is there and is very strong, then we may probably need larger studies or longer studies or other studies, and the studies that are coming to clearly identify the iron, the effect of IV iron. I have to say that you may have different views on the results of the AFFIRM-AHF because it was influenced greatly by the COVID situation. Because if you look at the COVID sensitivity analysis, that would have given abundant evidence for a class 1A recommendation. And there were also technical problems with the voting that didn't allow to get a class 1 in the guidelines, and Marco may wish to expand on that.
Is mortality reduction required for a class 1 indication? Because the previous trials showed at least improvement in quality of life, which is the same thing which has happened with so many other drugs.
I mean, Marco knows better than me, but it's you can use not just data on randomized clinical trials, but from meta-analytic approaches, and there are meta-analyses that basically show the efficacy of IV iron. So you can use the meta-analytic approach for a class 1 indication.
Yes. Go ahead. It's a criticism done to the guidelines, to the current guidelines on heart failure. And actually, I must say that it's true. They are very much based on mortality data. And this relates also to the way how ESC wanted the recommendations to be done. That is to say, they had to be voted by 75% of the task force members to be included. And this, of course, is a very conservative approach because to reach a 75% consensus, reaching this is easy if you have a mortality reduction. It's much more difficult if you have softer endpoints. And I think this is a problem, and it's a limitation, but it is what it is. And so, from this point of view, even the class 2 recommendation. I mean, but if you think, I mean, in one way, if you do not give treatment, you know that this treatment reduces mortality is something which is still perceived as much stronger than worsening quality of life. And the other point is that we do not have very strong scores, or at least they are not so commonly validated and accepted to assess quality of life. I think with the KCCQ we are moving very much forward, but may still be not as strong as with mortality.
Yeah, if I may ask Professor Togozoglu about preventive cardiology, a lot of preventive cardiology is related to policymakers and the government input. Is there any specific recommendation for the cardiac societies to transmit all of these guidelines into their Minister of Health or the policymakers? This is one question. And the second question is, when it comes to the risk reduction in some countries, perhaps producing polypill that can target 2 or 3 risk factors at the same time could be an answer. Is there any study on that or any recommendation on polypills?
First of all, for the first time in this guideline, we do have recommendations for public health, because in the past it was only for the specific patient. So for the first time, from global warming to air pollution, other environmental factors are considered, and there are suggestions for policymakers. However, of course, the science is there, and we try to put the science out there, but we cannot force anyone to adapt those recommendations, and every country has to take care of its own policy. We just put out the evidence-based medicine there, and the decisions to reimburse or to take it up are up to the individual healthcare authorities. There are very interesting studies about the polypill, and at the American Heart Association, some subgroups have been defined from previous studies showing which combinations work better compared to all of them. So should we combine a statin and aspirin and antihypertensive, and which ones work better? So there's a lot of evidence out there. However, the present guideline is emphasizing a lot of personalized prevention. In a way, it's too complicated. It's more than 100 pages, and there are subgroups trying to personalize. Although polypill has proven itself to be advantageous in a population level, for personalized prevention, of course, it doesn't have a place in the guideline. But it has shown its advantages in several studies, and more are coming up.
I think sorry.
No, go ahead.
Lali, I think the salt restriction guidelines are meant mainly for cold countries. You know, if it's a hot weather, like what happens in tropics or even several other parts of the world, and you are sweating away, there's no way you can restrict to 5 grams of salt or the fluid. So I think that has to be tempered with, kind of regional requirements.
For sure. And even the risk stratification system, we know that the best system is the one that is derived from the country it's going to be used for. So these are the European guidelines tailored for Europe. However, there's a new publication by Dr. Bath from Harvard, and he tried to use this model for other countries, and it seemed to work at least better than the previous guideline. It was pretty well because it's so tailored. But as you said, it needs to be changed according to each society. For example, Saudi have recently published their own guidelines, changing the European guideline and the risk stratification system according to their needs. So I think these are the general principles, but each country should adapt it according to their own. These work only for Europe.
Yes, and actually WHO also has adopted the policy of making the risk stratification based on the country level. So we have it in Saudi Arabia and in United Arab Emirates as well. And that SALT recommendation also, I think, Vijay, is coming from WHO recommendation. May I ask another question about heart failure and devices? Because all the positive device therapies studies, previous studies that have been done on the previous limited pillars that we were using in management of heart failure. So with the new development and the better outcome of heart failure, don't you think it's time that we test these devices on the new guidelines and the new therapies and see what would be the result?
Of course, I mean, if you mention mostly the occurrence of sudden death, that is lower, so probably we'll need a better assessment of the efficacy of the ICD in patients with modern therapies. But I mean, in my view, rather than a fresh new trial, it would be better to look at the shocks that are given in patients according to the number of medications that they receive, and that will give a better information on and easier to gather information compared to a new trials that may be unethical because it's you cannot now randomize patients to full medical therapy or not. So probably that is that will be the way forward.
Would there still be a major differentiation made between ischemic and non-ischemic etiology for heart failure when deciding about ICDs? There is some difference. It came on the basis of one of the studies, but then there was a criticism about that study also.
Yes, the indication to ICD has been downgraded to 2A from class 1 to 2A in the current guidelines because of this trial Danish showing a neutral effect of ICD on all-cause mortality in patients with non-ischemic heart failure. However, this trial showed a roughly a 50% reduction in sudden cardiac death also in these patients. And actually, what it clearly shows is that, I think, is that that of course the defibrillator doesn't work on non-cardiac death, non-sudden cardiac death. So if the patient has comorbidities, or if the patient is aged, so that we can predict that non-arrhythmic causes will cause his death. Of course, I mean, it doesn't make sense to implant a defibrillator. Otherwise, I mean, if the patient has a reasonable life expectancy, and even if he doesn't have an ischemic heart disease, the defibrillator should save lives no less than what we know from the previous data.
Question about GFR. We know that for ARNI, the lower limit is around 30. And for SGLT2 inhibitors, we have gone down to 20, and maybe shortly it will become 15 or something. What about somebody who's getting a combination of these two drugs? Would there be an additive worsening of GFR, or is there any particular guideline on that?
I think that on that, the guidelines are pretty clear. And they say that the transient decrease in renal function should not prompt the interruption. And even an increase of creatinine up to 50% above baseline, as long as it is with the creatinine less than 266 macromole, or a decrease in GFR more than 10%, shouldn't prompt any discontinuation. So that is important, because at the end, even if patients have CKD, if they have heart failure, they die because of heart failure. So it's I would, especially if patients have repeated hospitalizations and they are in the class 2, 3. I mean, I wouldn't care too much about the worsening of renal function, because they will die because of an heart failure event.
Notion?
Well, I think we have arrived to the end of this session. Once again, I would like to thank the three speakers for their presentation, and I would like to thank the audience for paying attention to this session, and wish you a pleasant evening, afternoon, wherever you are, and inviting you to attend the following session. Thank you.